Good morning, everyone, and welcome to another session of CME. Here we have allied consultants and allied specialities included. So the first Tuesday of every month, henceforward, we will have an allied specialty giving us a CME. Today we have Dr. Ranjit Peter, who's kindly agreed to talk on pediatric rhinosinusitis, a common problem that we see often. And the question is always whether to start antibiotics, if not, when, for how long. So we hope that the CME will clarify some questions and standardize care across the units. Over to you, Dr. Ranjit, and thank you very much once again.
Thank you, Dr. Brahmaram. Good morning to everyone. I hope I'm audible, Dr. Brahmaram. Can you confirm that?
Yes, you're very audible. Very good.
Yeah. All right. Yeah. Thank you. So I think this is a very relevant topic for all of us. And this talk specifically is slightly different from what I usually give in terms of I've realized that the pediatrics team in our hospital is a very academically oriented team. And I have tailor-made this talk to cater to the academic interests of our pediatrics team. So, but that's not just that. Of course, I believe there may be a few ENT surgeons as well. And probably, as you share it later on, or if it's shared, it will be useful for ENT surgeons as well. And primary care physicians or general practitioners, when they address a child with sinusitis, be it a 12-year-old or a 13-year-old or a 15-year-old. So it will be useful for everyone. So that's what I believe, and that's what we're going to get into. There's only one objective. It's basically to update ourselves with the recent trends and the paradigms in the pediatric sinusitis management. And to start off the whole thing, to kickstart the whole thing, I'll start off with a case report of a child that I had a couple of years back in India, an 8-year-old boy who was referred to us from a general practitioner who came in with a 7-day history of progressive painful swelling just above the medial canthus of the left eye. And he was already on a course of amoxiclav. He was on day 5 of the amoxiclav. But there was no fever. He had a history of allergy and recurrent rhinitis and so on. There was also just a coincidental history of, he was a very ardent football player. So he had a little, on close questioning, there was some history of head trauma, which not really trauma, but then, hitting the ball with the head. Otherwise, he did not have any major atopic history. The allergic symptoms, in the sense he had basically rhinitis, but not really, no asthma, no skin allergy, food allergy, nothing of that kind. On examination, he was afebrile, alert, but he had this erythematous tense cystic tender swelling just above the left medial canthus, as you see in this image. There was no nasal endoscopy was unremarkable. There was no pus, the middle meatus, because there was a little swelling, but no major, evidence of infection or inflammation happening inside the nose. Blood reports were almost normal. And of course, on examination, there was no restriction of eye movements, no diplopia. We also got an ophthalmology opinion. And of course, the pediatrician also was involved. And so we proceed on to do a CT scan. So this is the CT scan image. These are the coronal cuts. These are from anterior to posterior. You can see the frontal sinus here. It's filled with material. You can see a breach in the bone of the ethmoid and the frontoethmoidal region, the ethmoid sinus. You can see the bulging into and this is the posterior ethmoids, and you can see some kind of a little opacity in the maxillary as well as the sphenoid sinus. That was the coronal cut. Now, the axial cuts, you can see again the frontal sinus is full. There is the ethmoid sinus. This is, of course, the bone window, and you can see you can't really make out too much on the actual demarcation of the bone and the soft tissue. Now, this is soft tissue window. You can see. Sorry, next one. You can see in this CT scan, you can actually see. I'll just pause that there. You can see the you can see more or less some amount of bony thinning out and bulging into the orbit with some soft tissue edema and soft tissue swelling and so on and so forth here. But the whole frontal and ethmoid sinus are full. And of course, there's some amount of material in the maxillary sinus and some amount of collected material in the sphenoid sinus as well, which is probably seen here. You can see a little bit of probably edematous mucosa or something like that. So these were the findings. And so with these findings, of course, he was given a course of IV antibiotics, ceftriaxone, with clindamycin, in spite of the blood test being negative, in view of the tense cystic swelling and in view of the CT scan findings. So we waited for 24 hours. There was no change. The swelling was not reducing. The pain was not reducing. So finally, I reached a decision to proceed with surgical intervention. And so I went ahead and did endoscopic drainage of the frontoethmoidal mucopyoceal. It was mucopyoceal. There was purulent material, thick purulent material. And since this is a pediatric crowd, I'm not put the videos of the surgery here. And the culture was done, and the culture, to make the long story short, the culture was negative. It was sterile. There was nothing grew in that. And this is the image on post-op day 2. You can see the swelling has remarkably come down. And post-op day 6, it's almost everything is back to normal. So this is just an intro into this topic of pediatric rhinosinusitis and how, of course, we can have complications which have to be dealt with appropriately. And there are different schools of thoughts and so on. So we'll deal with some of those. So, if one were to look at the literature and evidence of different guidelines, there are the NICE guidelines, there are the American Academy of Pediatrics guidelines, there's the American Academy of Otolaryngology, Head and Neck Surgery, consensus statements. EPOS is the European position paper on prevention of sinusitis and nasal polyps. So there are so many guidelines and so many, and there are different years of their what they have come out with and what they have decided upon. And you can see how varied the paradigms are. For example, the Americans believe for chronic sinusitis, for chronic rhinosinusitis, you're supposed to give 20 days of culture-directed antibiotics, whereas Europeans say there is no high-level evidence to support short or long-term course of antibiotics. So basically, left with no, we can't really take a decision based on that. Yeah. Steroid sprays are recommended as beneficial by the Americans, whereas the Europeans say no evidence supportive, excellent safety record, but no evidence. Saline irrigations recommended beneficial, no evidence, supportive, excellent safety record. Leukotriene, of course, this is, remember, it's before 2020, this American consensus statement, but there are more recent ones which we'll deal with today. But what I'm trying to bring across is that, sometimes you can have varied opinions. And so that many times leads us to manage it the way we deem fit. And it can be confusing at times. So my point of this talk today is to update everyone with a more recent or the most recent updates and most recent thinking process from different parts of the world. But one of the articles that I'll be using. So I'm going to do this by using 2, 3 articles, which are more or less, consensus statements, or, they are more or less a summarizing statements, which give us a reasonable idea about how to proceed with things. So one of the articles that I've chosen for today's discussion is this article from the Italian Journal of Pediatrics. So just to be fair, I've chosen one, pediatrics journal and one ENT journal and so on. So that is, we'll be looking at a few articles, and I'll be summarizing them. I'll not make it too boring, but at the same time, there'll be a little bit of academics in that. So I hope you will bear with me, and I hope you will find that useful. This is a consensus statement about the treatment of sinusitis in children, especially in the Italian setup. This is an inter-society. All these short forms are all different kinds of, infection control board and pediatrics departments and biotech. There are a lot of different departments, different societies, and different universities, all their short form. So it's a consensus statement of the inter-society consensus of the treatment of sinusitis in children. And this is specifically for the Italian setup. Now, what is special about Italian setup is that they got a lot of resistant strains of Streptococcus pneumonia, for example. So they have to be special in their approach. And I don't think we are far off. I'm sure the world is a small village, and we have the global village. So it's all almost the same, whether we go to US or whether we go to Middle East, or wherever we are, everybody travels around. The second article that I'll be using will be the pediatric chronic sinus. This is an American article. This is dealing specifically with chronic sinusitis. So this is an interesting, though it's a little older, it's a 2022 article, but still there are a few high points which, probably will help us in dealing with pediatric chronic sinusitis. The third article I'll use, which will be the last article that I use, will be the safety and efficacy of systemic corticosteroids. The reason being, I'm sure in many of these situations, we tend to use steroids in different forms. And so it's important to know, what can be used, how long to use, and so on and so forth. So this is, of course, a very recent article, the 2026 article, and this is by the American Academy of Otolaryngology and Head and Neck Surgery. So these are the 3 things we will look at. So to start off with, let's start off with the first article. This is the Italian Inter-Society Consensus, like I said, and it's available. It's an open source article. You can, if you scan this QR code, you have access to the entire article. So let's look into what they have to speak about in terms of background epidemiology. We all know that sinusitis is basically inflammation of the paranasal sinus mucosa. And many times, if not all the time, it's a post-viral sequelae. So we do have the viral infection setting in. They come in with a flu or a common upper respiratory infection. And the thinking process is that it causes inflammation, stagnation of secretions, inflammation and swelling of mucosa, leading to retention of secretions, and that causes sinusitis. And that is the thinking process. The peak incidence usually happens in the pediatric setup in the age group of 2 to 6 years. The common understanding is about 0.5 to 2% of all upper respiratory infections become bacterial sinusitis. The chronic sinusitis prevalence is 2.1%, and the most common pathogens, of course, they call it the big 3: Staphylococcus pneumonia, H. influenza, and Moraxella catarrhalis. Not to forget, group A and B streptococci can also be there. There can be some anaerobes once in a while, fusobacterium, and so on. All those are also there, but the most important are these 3, and we must know that. The diagnosis is primarily clinical, and the general understanding in acute sinusitis is that we don't really depend on imaging for the diagnosis. So what are the diagnostic criteria? So we have what is called as acute sinusitis, when you have any two of these three symptoms, that is nasal congestion, discharge, and cough. Now, this is something that I like to highlight. Whether it be acute sinusitis or chronic sinusitis, cough is an important symptom in children as against adults. And the understanding is that this cough is generally because of postnasal drip. So when you have more than more than any of these, either two or more, two or all three of these symptoms, if it's lasting more than 10 days, we're talking about, a person having a general flu and then they get well and they go on. But some of them, they may have persistent uh, symptoms for lasting for more than 10 days. Or some of them may have, a flu and then they recover, say after 5 days or 6 days. But then after some time, again, after a few days, again, they start developing symptoms. So we're talking about people who have symptoms, children who have symptoms either 10 or more than 10 days. Then we have this category called subacute sinusitis, wherein you have symptoms lasting 4 to 12 weeks. That means 1 month to 3 months, basically. And chronic is anything more than 3 months. Recurrent is when you have more than two episodes within 30 days, but separated by more than 10 days. So this is another category, recurrent. And you have recurrent acute when you have more than or equal to 3 episodes in 6 months or 4 episodes in 12 months. So these are all definitions purely for the sake of, again, academics. But we must recognize that this is all, a part of sinusitis. And of course, one must rule out when it comes to these symptoms, one must rule out other things like, a bronchiolitis or, respiratory lower respiratory infections. And all those things have to be ruled out. However, we're talking about specifically these three symptoms alone, or either two of them. For example, if they just come with a long-standing cough with nothing else, we must look at possibility of sinusitis with, if they have any nasal symptoms with cough lasting more than 10 days, we must think of possibility of sinusitis. So that's what we're trying to get at. What are the recommendations? Recommendations for acute sinusitis. This is, again, mind you, this is the Italian paper, and their consensus among all their different faculties is that, empiric antibiotics are indicated for uncomplicated acute bacterial sinusitis. Now, what are the criteria for starting the antibiotic? It's persistent symptoms more than 10 days, worsening after some improvement. That means there is an improvement in symptoms, like I said, mentioned earlier, and then it again worsens. Or if there's a severe onset, like very high fever with no actual lower respiratory tract symptoms. So these are all criteria for starting empiric antibiotics. But though the recommendation is weak, but it is a recommendation nevertheless. And it's moderate to low quality evidence as well. In subacute cases, consider antibiotics if not already given. Okay, and of course, in these situations, in subacute cases, they recommend referring to specialists if no response to antibiotics. Now, we must remember that many of these guidelines, whether it be the NICE guidelines, whether it be American guidelines, whether it be Italian guidelines, or whatever guidelines, many of these guidelines are meant for the public health. And so public health is, where there's a definite referral pattern, and when there's a lack of, sometimes the specialists or subspecialists are not available. So that's a different level of referral. But then when it comes to a place like Bahrain, again, just like I mentioned the last couple of seminars when we had that, we must, if there is any, difficulty or if it's not responding, then you must refer to an ENT as well for a collaborative treatment. Okay, yeah. So what are the antibiotics of choice? The first line of choice is, of course, amoxicillin or amoxicillin clavulanate. However, in the Italian guidelines, as against the American guidelines, the choice of the amoxicillin dosage is a high dose. That is 90 milligrams per kg per day in 3 divided doses, whereas the American guidelines actually speak about 12 tavali. You can give it even 12 tavali. But the Italian guidelines mention very clearly 3 divided doses and 90 milligrams per kg body weight. And the reason why they do this is the justification for this is that they have a lot of resistant Streptococcus pneumonia strains. And it's a high prevalence of that. So that's why they do that. And the duration should be at least 10 days. So that is, again, the bottom line. And they don't recommend topical antibiotics. The reason why I say that, again, there are sometimes, there are some places, some guidelines where some people have tried things like, in the nasal wash, they put gentamicin and so on. So that is not recommended. And they very, very strongly recommend avoid low dose amoxicillin. That is 30 to 40 milligrams per kg per day. Chronic sinusitis, the guideline is systemic antibiotics are not recommended in the Italian guidelines. Systemic antibiotics are not recommended because there's no evidence about any specific antibiotic agent, and assessment has to be very, very clinically oriented. It is the symptoms which we mentioned, plus a rhinoscopy. Rhinoscopy can mean either looking straight into the nose. You can even use your otoscope to look into the nose, or you can use, or we use an endoscope, and we have that as one of the guidelines. And the SNOT score is the we have the grading SNOT 22. Sorry. We have the grading, the SNOT 22 score, wherein it's a severity of the nasal symptoms. Then, of course, the MRI may be helpful in mucosal evaluation. We are talking about chronic sinusitis, wherein they have already received some treatment and it's long lasting. So there's an evaluation process also happening parallelly. So this is the MRI, role of MRI and role of CT. CT is mainly for surgical planning. MRI is if in case you are looking at, you want to look at the mucosal involvement. All these are subject to discretion. Complications are more common with chronic sinusitis in children less than 5 years. Then, of course, coming to recurrent sinusitis. Recurrent sinusitis, as we mentioned earlier, is more than 3 episodes in 6 months or 4 episodes in 12 months. And we must remember things like play schools, daycare centers, allergies, smoke exposure, anatomical issues, all that. And there's no specific prophylactic antibiotic recommendation. Specialist referral is definitely indicated. So what are the recommendations? The recommendations are this. The Italian guidelines, the consensus statement, the recommendations are these. In acute sinusitis, empiric antibiotics are recommended. Subacute sinusitis, antibiotics should be started if it's not yet given. And the first line is a high dose of amoxicillin or amoxicillin clavulanate, but it has to be a high dose, 90 milligrams. And there's no role for topical antibiotics in acute sinusitis. So there's a strong recommendation against the use of topical antibiotics. Diagnosis is clinical. Imaging is not routinely indicated. And antibiotics for acute cases with strict criteria. I mean, the criteria are very clear. Avoid antibiotics in chronic sinusitis. Monitor the complications in young children. Antibiotic resistance is a major concern, as we all know. So antibiotic stewardship is important. So this is from the first article. Okay. We will have a discussion at the end, so we can take up some questions after that. The second article is, like I said, it's an American article, and this is it's from 2022, but it's about chronic sinusitis. And the purpose of this article was to review the diagnosis and management of pediatric chronic sinusitis and highlight recent advances in surgical and medical treatment. This one is interesting for ENT surgeons because there are a couple of high points in this, which I found quite useful. So as we again redefine that, pediatric chronic rhinosinusitis involves inflammation of nose and sinuses. the load of pediatric chronic rhinosinusitis is quite huge. 5.6 million. This is the US statistics, of course. 5.6 million annual visits of CRS in the ages 0 to 20. 2.1% of pediatric diagnosis. That's a huge thing. Requires more than or equal to 2 symptoms of more than or equal to 12 weeks. We already said that the chronic is more than 3 months. That's 12 weeks. So what are the symptoms? Symptoms are again nasal obstruction, congestion, facial pain or pressure, cough, and purulent rhinorrhea. So these are 4 symptoms, and you need at least 2 or more of these 4 symptoms. Remember again, like I said earlier, the cough is an important distinguishing symptom in a child as against an adult. So that is something we must keep in mind. The diagnosis is by objective signs. So we are supposed to do an anti-rhinoscopy, endoscopy, and we look at these objective signs. What are the signs? We look at mucosal edema, purulent discharge, usually from the middle meatus or sphenoethmoidal recess, and nasal polyps, if at all they are there. If you're doing a CT scan, we look at sinus mucosal thickening and osteometal complex, the sinus drainage area opacification. So these are objective signs that we look for in chronic sinusitis as an evidence of a chronic sinusitis and rhinosinusitis. So CRS usually may follow multiple viral upper respiratory infections. So that's why we say that antibiotic is not recommended in CRS. 2% upper respiratory infections progress on to acute bacterial sinusitis, but the pathogenesis is it's still poorly understood. So that's why again there's a lot of gray area in that. Organisms are again similar, the same organisms, of course, and we generally recommend a culture guided therapy if empiric treatment fails. So empiric treatment doesn't include antibiotics in the beginning. Middle meatus cultures correlate well with sinus aspirate. Now, I must tell you in this statement, the gold standard is considered sinus aspirate. Now, how do you get a sinus aspirate? You have to puncture or you have to get into the maxillary sinus and get the, imagine the aspirate. Imagine doing that for a child, which is not a practical solution. However, a middle meatus culture is the next best thing you can do. It's almost 78% almost the same as a sinus aspirate. So this is all based on studies. Nasal endoscopy, like I said, we look at, you can do an anti-rhinoscopy just directly with headlight, or you can do an endoscopy. Many times with that rhinoscopy, you may not see anything much unless you are an ENT surgeon. You may be a little more trained to look into the nose with even an otoscope for that matter. But you may not otherwise appreciate too much. Endoscopy, of course, is generally done in ENT clinics. Anti-rhinoscopy, you look at mucosal edema and purulent discharge. Endoscopy, of course, you have a better view and you also get to see the adenoids. Nasal polyps, if at all they are there, they generally suggest cystic fibrosis and allergic fungal sinusitis, which are important conditions and they need proper addressing. So sorry, I had these images. So anyway, so this is about cystic fibrosis. You can see the completely opacified sinuses, and you may see some polyps, and usually there'll be thick secretions as well. This is allergic fungal sinusitis. You can see the different heterogeneous, opacities inside the sinuses and expansile bony margins and so on. And endoscopically, when we open it, you will find this kind of pultaceous clay material, sometimes cheesy material, which is there in the sinuses. Now, these kind of situations, of course, needs surgical addressing. This is, of course, an antrochoanal polyp. If at all, a unilateral polyp is generally antrochoanal polyp, nasal antrochoanal polyp. So these are all conditions that we see on endoscopy. Systemic diseases, we must keep in mind that the chronic rhinosinusitis may at times be a signal of cystic fibrosis, primary ciliary dyskinesia, syndrome, and immunodeficiencies. Many times you have these immunodeficiencies. And you have vaginas, Schuck-Strauss, the GPA, what we call the GPA is basically vaginus, and the polyangiitis, eosinophilic granulomatous polyangiitis and granulomatous polyangiitis. So these are all the different conditions we must keep in mind. Asthma and allergic rhinitis are usually comorbidities. We know that it's a single airway and all that. So diagnostic imaging is indicated if they are not responding to conservative care. We'll talk about the conservative care a little later, but so imaging, CT scan is most of the time preferred, because imagine the child having to lie in an MRI. It's not really practical without sedation. Even CT scan sometimes can be tricky. So CT scan is sensitive for mucosal inflammation and anatomy both. So surgical planning as well as assessment both can be done with the same CT scan. MRI is strictly reserved for suspected intracranial or orbital complications. When you want to demarcate, the extradural or the dural involvement or meningeal involvement and intracranial involvement, you need to have an MRI. We generally avoid plain radiographs because it's got a lot of false positives and false negatives because of the the opacification. Generally, even a child with a running nose, if you were to take an X-ray, that's going to show sometimes some secretions inside the sinus, which doesn't mean anything. So generally, X-rays are not really recommended. Remember that CT scan in children is a big deal because they say 60 milligrays of cumulative dose increases the risk of brain tumors and hematological, malignancy like leukemia and so on by almost threefold. So that is something we must keep in mind. So radiation risk must be considered when we do CT scan. Medical treatment. Medical treatment. Here the evidence of antibiotics is limited, but again, amoxiclav is the recommended drug of choice in the European guidelines. And this is the Infectious Disease Society of America. So the American guidelines again here. European guidelines mentions amoxicillin, whereas the American Infectious Disease Department recommend amoxiclav at 45 milligrams per kg per day, divided into 12 hours. It's actually 45 milligrams per kg per day, divided over 12 hours. This is 12 hourly. Or a dual therapy, that is in those who are allergic penicillin allergic, they recommend dual therapy, that is with the third generation cephalosporin plus clindamycin. And they recommend 20-day course. A 20-day course is superior to 10-day treatment, according to the American Association of Head and Neck Surgery. The medical treatment for IV antibiotics generally is only for refractory cases, and they're also with culture guidance. So it's not just randomly started out of the blue. There are places where they give IV antibiotics in, of course, refractory cases for up to 4 weeks. IV antibiotics. So imagine the IV complications, like the line and other complications caused by that. So these are all, treatment tried out in different places. And so we must be aware that, we must not misuse all that. So generally, medical IV antibiotics are not routinely recommended as in the Italian guidelines. Even the European position paper doesn't recommend antibiotics. Now, coming to steroids. So intranasal steroids are recommended as first line of therapy. So what is the basic treatment for CRS? Not antibiotics initially. Intranasal steroids are recommended as first line of therapy. Oral steroids are also, tried when combined with antibiotics. The reason being, the whole idea being you're reducing the edema so as to facilitate the drainage of the sinuses. And we must remember systemic steroids, the side effects when it's given. And mind you, their dosage is generally like, as you can see here, the methylprednisolone 1 milligram per kg per day, not more than 40 milligrams. for 10 days and then tapered over 5 days, total 15 days. So we must remember the side effects they can carry. Saline irrigation is again something very safely recommended. Daily saline irrigation recommended as an adjunct therapy. There is definite symptomatic improvement seen in such patients, and it's generally reasonably compliant. The compliance is good, and children tolerate reasonably well. Coming to biologics, it's typically for type 2 inflammation in chronic rhinosinusitis with nasal polyps. And you have these two biologics, dupilumab and omalizumab, both of them, which show symptomatic improvement. Of that, omalizumab is a better one because it takes care of many more scenarios. And what's the advantage of biologics? It reduces the surgical intervention many times. Now, this is something that I would like to highlight. This slide I'd like to highlight for our ENT surgeons. It has been well studied now. There have been several studies. I can share the articles wherein it has been observed that almost 80 to 90% of patients who had CRS, their adenoids have biofilms. So we're not talking about the size of the adenoids. We're speaking about the adenoids just being the reservoir of infection. And, if it's somebody with allergy, for example, they don't have these biofilms. So it has been proven that children with chronic rhinosinusitis, the adenoids are many times the source of infection because they remain as the reservoir of infection. So it becomes, in both the European position paper as well as the American Association guidelines, adenoidectomy is the first line of surgical treatment. In CRS, which is not responding to treatment, which is not getting managed, the first line of surgical treatment is adenoidectomy. We're not talking about size, mind you. We're talking about purely the definition of chronic rhinosinusitis and the role of adenoidectomy for intractable or which is not getting controlled with, say, for example, saline irrigation, steroid sprays, or even for that matter, culture-directed antibiotic therapy. If it's not getting controlled, we have to think of adenoidectomy. And for the ENT surgeons specifically, if there anybody attending, many times when we do the adenoidectomy for these situations, when we're talking about CRS in chronic rhinosinusitis, if you're doing adenoidectomy, where the pediatrician refers to us for an adenoidectomy, it is a good practice to do a maxillary sinus irrigation in the same process. Under GA, it's a good practice to do maxillary sinus irrigation, either do an MMA and flush the maxillary sinus, and that is practiced and recommended. The other option is balloon dilatation, but the problem with balloon dilatation is it is expensive, and the only advantage of balloon dilatation is it's less traumatic, and it's very good for maxillary sinus, but for frontal sinus is a question mark because the frontal sinus drainage pathway is variable. But still, it is in the US, it is highly recommended, but in Europe, it is not very much, not very much in fashion simply because of the cost factor. So the advantage of balloon dilatation is not only do we dilate the ostia, but you also can do irrigation. So that is the advantage, and it's a safe procedure with good symptom involvement, and there's not really much of any other complications like synechiae formation, or even for that matter, bleeding is not there, and you don't really need to do too much of follow-up after that. So that is quite good. So balloon dilatation, the advantages are all these, that, it facilitates irrigation, there's not much of dissection, and, not really much of blood loss. The disadvantages are these. It's quite expensive, and it's a single-use, kit, and it's expensive. it's contraindicated in patients with nasal polyps or extensive mucosal disease because you can't access. So this is it's a little controversial, but it is a good option if cost is not an issue. And of course, we have the age-old endoscopic sinus surgery, which is reserved for CRS, which is unresponsive to adenoctomy. Remind you, we've done the adenoctomy first and then proceed on to CRS. It's got a high success rate and low complication. Now, mind you, this is again for very, very specific indicated cases, not for everyone. Wherein, for example, you have a fungal sinusitis, so where you have extensive osteomeral complex disease, which is not responding to medical treatment. So conservative approach is recommended for uncomplicated cases. And so that is the so the key points from this article are: medical therapy is, of course, the first line. CT is preferred imaging modality, keeping in mind radiation concerns. Surgery is indicated if medical therapy fails. And adenoctomy plus maxillary irrigation would be the first line of surgical management if it becomes indicated. And of course, balloon catheter dilatation or conservative FES may be given. So that is that. And coming to the last one of my, academic talk, I hope it's not too boring. The safety and efficacy of the systemic corticosteroids in children with orbital complications. So, like, for example, the child that I showed you in the beginning, the question is, what should we do? There is no pus in the middle meatus. There's nothing else happening. And yes, it is possible to aspirate through the swelling, which I showed you. But then that becomes a procedure in itself. So might as well go and debulk it from endoscopically. So these are all the thinking process. And so when it comes to these kind of things, steroids become an important part of the initial management trial, if you want to call it that way, whether it will reduce with steroids. So this is the article. This is again based in it's actually from the Children's Hospital of Philadelphia, Pennsylvania. So this is from there, and they did the study basically. It's actually, but this is a very small. I mean, it's not a very big study. It's a retrospective study to evaluate the safety and efficacy of systemic corticosteroids with the focus on children with orbital complications of sinusitis. It is known that 6 to 9% of children with upper respiratory infections develop sinusitis. 5% of pediatric sinusitis have complications. Orbital complications account for almost 80% of all complications. We know the Chandler's classification, the preseptal cellulitis, wherein they come in with lid edema, then orbital cellulitis, then subperiosteal abscess formation. For example, that's what we had, though it was a frontoethmoidal mucocele, there was a subperiosteal abscess formation. And then orbital abscess per se, and then, of course, cavernous sinus thrombosis. So these are the five, the typical Chandler's classification that I'm sure all of us are familiar with. What are the signs? The signs are erythema, edema violates, proptosis, ophthalmoplegia, diplopia, vision loss, afferent pupillary defect, and of course, depending on the optic nerve involvement. This was a retrospective study, and it included basically orbital cellulitis with or without subperiosteal abscess patients, excluded preseptal cellulitis and intracranial extensions. And the outcomes they measured was the length of stay, surgery, readmission, and so on. They found that, among the whole lot, 12% of them, actually, it was 257 patients, of which after eliminations, 222 patients. So this is 12% received systemic steroids, 65% received IV dexamethasone or methylprednisolone, 35% received oral, and 62% received 1 day course. Some people received 2 to 4. Some children received 2 to 4 days course. And so the results were this: the steroid use can reduce the need for surgery, which is an interesting or a very relevant point or relevant inference. And there's no difference in length of stay or readmission when you compare the two. And there was no cases of vision loss or secondary infections. This is something important. So interpretation is this: so the steroids may reduce inflammation, improve drainage, and findings align with all the other previous studies that are there. Short courses may offer benefit with minimal risk. So this is what we must remember. As against the other, what we mentioned about, 10 days plus 5 days, short also can be tried. The limitations, retrospective single center design, not a standardized steroid regimen. That's where we are still left in the dark. There are no clear-cut guidelines of regarding steroid use. But still, the overall conclusion is systemic steroids appear to be safe in orbital cellulitis. They may reduce the need for surgery, and we need to do more studies. So this is where I will stop, and I think I have used exactly 45 minutes. So I will hand over to Dr. Brahmara, and we can take any questions or any clarifications and open it for discussion. Dr. Brahmara, over to you.
Yeah, thank you so very much, Dr. Ranjit. The forum is open for questions. Anyone has any questions, you can either unmute and speak or put it up in the chat. Thank you for that very informative lecture.
Most welcome, but I usually don't do these kind of, I prefer more clinical, case and case-based this thing. But this is very academic. So I
Yes.
found my slides were a little too academic. So I hope that helps some people somewhere.
So summarizing my understanding of your lecture is that it's common, about 0.5 to 2%, but in one study it went up to about 5 to 6%. I think it differs from
it differs from place to place. Yeah,
correct. It differs.
Yeah.
And then it can be as young as 2 years, 2 to 6 years is the most common age group, because I think maxillary and ethmoid sinuses are already present at birth.
Yes, yes. Usually it's maxillary or ethmoid sinus. Ethmoid sinuses are more common. Maxillary and ethmoid both are there.
Yeah,
right.
Are there. It's the sphenoid that develops later, and the frontal is the last to develop around
frontal
6
last, yes.
years.
Right?
Yeah. So the three main symptoms that are required for diagnosis of sinusitis, two of these three, that is discharge, congestion, nasal congestion, and
the cough. Cough is the special symptom.
Yeah. So are these also the same for adults, or is cough pediatric specific?
No, the cough is not really there in the adults, isn't it? So cough is specifically for children, because in adults you have the other symptoms like the sinus headaches, the nasal congestion. Of course, you have endoscopic findings as well. But the cough is specifically for something that differs from adults is the cough. Generally, we don't, even I don't think we generally consider the cough when it comes to diagnosis, but that is the diagnostic criteria, the cough.
Yeah. Okay. So when you say nasal discharge, is it a nasal discharge? Are you looking at post-nasal discharge, or is the nasal discharge that we talk of is rhinorrhea?
Yeah. So that's an interesting thing, because one of the, if you look at all the different literature out there, just the presence of a yellow, what appears to be mucopurulent, need not be bacteria. So that's why the argument against antibiotics. So many times yellow, generally patients come to us, or the parents come and say, oh, the child has got yellow discharge. Yellow discharge doesn't always translate as bacterial infection. Yellow discharge many times only means that there is WBC, and there are stagnation and so on and so forth, but it doesn't always grow bacteria, and this is as per studies. So nasal discharge is even what would appear to be mucopurulent discharge, unless of course it is proven by a culture or something like that. So that becomes any kind of nasal discharge. Yes.
Yeah. So that yes, Dr. Ranjit. So it's both anterior and posterior. That's what it is, right?
Yes.
Both,
yes.
It's fine.
The cough is primarily because of the postnasal drip.
But it's interesting that the cough, the postnasal drip would be there even for adults, isn't it?
Yes.
That's
But then I guess they see again this is nighttime and daytime cough which is there. And in children, they are they they're not used to swallowing, and I guess I don't know, that may be some of the factors. But the cough is a very important, especially long-standing cough, which is not accounted for by anything else.
Yeah.
Is generally would become, like for example, there's no chest findings, but the child has cough um, in the presence of nasal congestion or the pressure and so on. So those are all the symptoms that we mentioned
Right.
are indications to suspect sinusitis.
Yeah. Another thing you mentioned was sinusitis is basically a clinical diagnosis. You don't really rely on imaging unless you have any
Yes,
complications like orbital complications. Now, with
that's
respect
right.
to clinical findings, apart
Yeah.
from these three, these are the symptoms that you find, and of course, some
Yeah.
objective evidence. But
Yes.
um, uh, do we not routinely do uh, sinus pressure points to find that there is tenderness on sinuses? Could you just talk about that?
So
I know the
yeah.
frontal
So
sinus.
yeah. So one more thing is the symptomatology. So generally, one thing that that's I didn't mention that because probably I thought that was that was understood or everybody would know. So we're talking about frontal sinus pain would be generally in the frontal region. Maxillary sinus would be in the cheeks. Ethmoid sinus would be. We're talking about different age groups. I'm not talking about just a 2-year-old or a 5-year-old. I'm talking up to maybe 10 or 12-year-old. So we're talking about frontal sinus also. Yeah. Um, the ethmoid sinus would be in the temporal region, and sphenoid sinus would be in the occipital region. So for example, I had this child. I think he was 5 or 6 year old, who came in with occipital headache, and his nose was good, everything was good. But even anti-rhinoscopy didn't show anything. But when he did endoscopy, there was definite mucopus coming from the sphenoethmoidal recess. And then upon CT, there was isolated sphenoid sinusitis. So this
Oh,
is a 5-year-old, mind you. So it does happen. So we must remember the localization, regionality, or the localization of the pain that they complain of is an important hint for the sinus involved, if there is sinusitis.
that's really an interesting point. So you need to look for the occiput tenderness as well to rule
No,
out.
no, not tenderness. Occipital, there's no tenderness. Occipital is a pain, isn't it? The
It's
child will
only the
complain of
pain,
pain.
complain
Yeah,
of
yeah.
pain. Yeah,
The
because
pain they will
normally,
complain for the sphenoid sinus will be in the occipital region.
right.
Yeah. Have you had any case, any, see, I've had, in fact, over the last, say, 3 months, I've had one or two pediatric sinusitis, which is not responding to treatment in terms
Mm.
of we had to do multiple endoscopic toilet here and then steroid course, and of course, it settled down. But we've had a couple of cases. The only thing is those recordings may be there in our system, but I can share it.
Yeah. So, and what is the you've shared different studies, different areas.
Yeah,
The Italian study that recommends a high
yeah,
dose amoxicillin 3 times a
yeah.
day.
90
When
milligrams per kg per
yeah,
day. That's quite a high, quite a bit,
so
isn't it?
what I guess that also depends on the region specific antibiograms. So based on our
Yes.
hospital, I'm talking specifically about our region in Bahrain,
Yeah.
and
Mm.
also specifically our hospital. So
Yeah.
what is the dose that you normally recommend when you're treating a child with acute sinusitis?
We give we give the ES version here. I
High
mean,
dose, high
yeah,
dose, and 12th
high
hourly.
dose. Yes, yes, yes.
Yeah, and
Yeah,
it's a
but
course for 10
they
days.
recommend 8 hourly because they say amoxicillin has got short half-life. Ideally, yes, it is true. That recommendation is true. I mean, the Italian study says you must not give 12th hourly. You must only stick on to 8th hourly dosage. The Americans say you can do 12th hourly. So either way is, I guess, acceptable. Good morning, Ram. Yeah. There was a question. Somebody's asking something.
Yeah. So the duration is for 10 days, right?
Duration has to be 10 days for acute. For acute. For chronic, at least they recommend 20 days. Now, do we give 20 days? I don't think so. Generally, we give for 10 days. The recommendation is 20 days.
Right.
For chronic. And by the way, there's also another point that I probably didn't put up in the slides, is macrolides are not really recommended. Though, ENT side, we do have an affinity for sometimes in CRS, especially in CRS with polyps, there are a lot of thought processes among different people, even in India, wherein we give 3 months of macrolides in a smaller dose for the immunomodulatory function of the macrolides. There are a lot of studies on that, of course. There's evidence on that. But at least in the Italian and I think the US one, they have said very clearly macrolides should not be used simply because, of course, it is short term, simply because they increase resistance. So that's what the justification given for that.
Yeah. Any other questions before we close? I think there is one. What about adjunct with Montelukast? There's a question from Dr. Maricel.
Yes, yeah. That's an important point. Montelukast, as you know, would always be something that we must keep in mind. I don't know whether you saw the initial guideline thing, but as you know, that we must, whenever we give Montelukast nowadays, it comes with a warning. There's a black box warning about behavioral, especially in children with behavioral issues, or if they develop behavioral issues, to stop it. Yeah, so you can see this in this slide in the 2014 consensus statement and EPOS 2020. The leukotriene modulators, if there is asthma and allergic rhinitis, then you can use it. However, it's our responsibility to tell the parents that there is this, and many of the parents will come and tell you, I saw this warning on the box, on the all the boxes that are available here also, it shows the warning. So we must inform them about that. But otherwise, yes, it does really good, but we must give it for at least 3 months.
That was my next question, as to the minimum duration is 3 months.
3 months.
And then you taper it off.
The same goes for the complication of all this, the otitis media. They say 3 months. Leukotriene. I'm talking about Montelukast.
Yeah. All right. Thank you very much, Dr. Ranjit. I won't keep you long.
Thank you.
Just
Thank
2
you
minutes
very much.
to 10.
I hope it was not too boring. Huh?
It wasn't boring at all. It was very useful. And I think it will certainly impact the way we handle and treat sinusitis. Yeah. And of course, we know where to refer to if at all we get into cases where they are resistant to treatment, or we end up having chronic sinusitis.
Yeah.
Thank you so much, Dr. Ranjit.
Okay, thank you so much. Thank you very much.
Thank you.
Have a nice day.